Good afternoon, and thank you for joining us today. My name is Darcy Belito de Luna, and I'm the Continuing Education Manager at the American Institute of Ultrasound and Medicine. As part of the AIUM's advocacy for healthcare professionals, I am honored to host this webinar with renowned members of our community leadership, Dr. Dolores Pretorius and Mishella Perez. Today's webinar will explain methods for expediting the duration of obstetric ultrasound exams to reduce risk exposure to COVID-19. Guidance on billing codes for fetal anatomic and first trimester exams will also be provided. If you have questions for the presenters during this webinar, you may type them into the question box on the right side of your screen. You will be able to submit questions throughout this webinar, but the presenters will not begin answering questions until they have completed their presentations, at which time they will answer as many questions as possible. A recording of this webinar will be available on the AIUM website. And now I am pleased to begin this presentation with Dr. Dolores Pretorius.
Here we go. I'm showing the main screen and I'm trying to find how to play on this one. Let's try it here. There we go. Thank you for this honor to be able to talk to you this morning about expediting obstetric ultrasound exam times. Mishella Perez and I have worked together for many years, and she was asked by the AIUM to talk on this topic, and we decided to do it together to give you both of the perspectives from the University of California, San Diego, as well as Scripps Health, and I'm very honored to work with her to be able to do this for you. When COVID, the virus became much more prominent and we were aware that there was a lot of risk to the healthcare providers as well as the patients, we decided that we needed to decrease our exam times to reduce that risk. We basically took our exams and decreased the times by moving to a shorter exam that would follow all of the guidelines, but allow us to do the exams much faster. These expedited exams are to be used during extraordinary circumstances, but particularly during the current pandemic of COVID-19. We know that healthcare providers are at the greatest risk, and some data shows that 10 to 15% of the patients with virus are healthcare providers. And that's because we are in close proximity with our patients for a prolonged period of time. So we shortened our exams, put out new protocols, and then we sent out a survey that Mishella Perez and I put together and sent it to our sonographers as well as to our perinatologists and asked for their feedback on how they felt about our shortened protocols that we're going to go over today. Dr. Andrew Hull, who is the chief of our fetal center at UCSD and is a professor in the OB-GYN department, said, fine. It feels like going back 5 years. And I think that is really true. Many of the views that we have added over the last 5 years, things having to do with the orbits, the lenses, the palate, the posterior fossa, we have eliminated many of those views because we are trying to stay just with the guidelines in order to shorten our exams. And we do hope to go back after the virus pandemic is over to zooming our ability to look at all of the fine detail that we've learned to look at to find small anomalies. Dr. Miriam Tarza from UCSD, also a professor, said that at a university practice, I feel that misdiagnostic rate should not be affected. We have highly qualified sonographers. It seems even though not in the protocol, their eyes are trained and minor abnormalities will likely be picked up. And then Dr. Fox from Scripps Clinic, perinatology there, she said, I particularly appreciate the cine clips when documenting abnormal anatomy, and I think these cine clips are particularly useful in the first trimester for documenting early normal anatomy. So I think I'd like to review the recommendations given by several national, international organizations, including the Society of Maternal Fetal Medicine, the International Society of Ultrasound and OB-GYN, and the World Federation of Ultrasound in Medicine and Biology. We'd like to provide strategies for expediting the OB ultrasound exams in order to reduce the risk to the maternal care, medical care providers, including physicians, sonographers, midwives, nurses, and the staff. We're going to provide modifications of the current protocols at our institutions, discuss the use of technology, including cine loops, PACS workstations, and 3D ultrasound. We will not be covering the cleaning of equipment or rooms, and we will not cover frequency of ultrasound exams. So first off, there does need to be screening for the symptoms of COVID-19 before the exam. So most of our clinics are calling the day before the ultrasound exam on the phone and asking about symptoms. Patients who are symptomatic, who have been diagnosed with COVID-19 within the 2 weeks, last 2 weeks, or who are under investigation should not be instructed to come for routine ultrasound exams. Patients are also being screened before they enter our waiting area by phone or in person. And again, they're asked about symptoms of fever, cough, shortness of breath, loss of smell, and taste. And as you would expect, these symptoms have been updated over time so that, for example, the smell and taste were added more recently. The others have been there for the full time, and we may have new symptoms come up that we ask for in the future. When I sent out the survey to other institutions, I found that some centers are testing temperature for temperature as well before they enter the waiting area. I'd like to just say one thing about masks and gloves during the ultrasound exam, and this is for our patients who do not have symptoms that we're doing in the outpatient setting, that these guidelines for us of what we're doing have been updated over time, that they are updated based on availability of masks and gloves, and I would expect that will be the same for you. Currently, at both UCSD and Scripps, sonographers wear surgical masks all day. They do not wear N95 masks. They wear plastic goggles for transvaginal exams and for invasive procedures. And our patients are generally wearing masks. They're supposed to be wearing masks or we give them one. And then disposable gloves are used during the ultrasound exam, and they are changed after each patient. Now, ultrasound time considerations have been presented by all of our major organizations that I'm going to talk to you about today. The Society of Maternal Fetal Medicine has said that we need to shorten the ultrasound exam duration as much as feasible based on indications and need. ISUOG, the International Society of Ultrasound in Obstetrics and Gynecology, says we should minimize the duration of the close physical contact between the patient and the sonologist. And the World Federation of Ultrasound in Medicine and Biology says that in order to reduce the risk of transmission, it is important to respect the time of the scheduled visits. So pretty clearly, all of our organizations are saying that we need to decrease the time. So I think I'll go first into the Society of Maternal Fetal Medicine recommendations. One thing that you should all be doing is minimize the clutter in your ultrasound rooms so there's less things that need to be disinfected and that could likely get the virus and transfer the virus. We should reduce the number of transducers on our machine to 2, one low frequency transducer and one high frequency transducer. We are keeping the transvaginal probe outside the room as SMFM recommends. We should store transducers when not in use. So our 3D probes are no longer on the machine. They are stored and can be pulled out if we need them. We are cleaning the room every morning and afternoon, and SMFM says computer keyboard, mouse, doorknobs, beds, chairs, ultrasound machines, countertops. And several of the other organizations have a longer list here, but the idea is that you need to disinfect twice a day. One little pearl that you might like, that I liked from these recommendations, was that the sonographer should open the door to the ultrasound room, not the patient. How about, what are the organizations saying about visitors? Well, the SMFM says that you should screen the visitor as well as the patient, but that the visitor should not enter the ultrasound room. The International Society of Ultrasound and OB-GYN says that no accompanying person at the visit and no trainees should be involved. And WFM says limit to the maximum of one visitor and no children, no trainees or students. And they encourage video call applications during the exam. For example, at UCSD, we allow families to FaceTime between mom and their partner at the end of the exam, not throughout the exam, but at the end, we leave a cine on the machine and they can show that cine to their partners if they like. SFM recommends that we save movie clips for fetal anatomy rather than images. We adjust the ultrasound exam based on indications and need, and that we focus on the mandated planes unless otherwise indicated. I would add to that that some clinics are saving videos or 3D volumes and do offline capture of still images from those. Offline annotation can be considered. Is it going to be faster for you to do it? This may help you in some circumstances. And videos can be cumbersome on some workstation programs. And we've heard that for some physicians, the videos just don't work very well, and others, it's a great tool. So SMFM has recommended that both for the low risk 76805 and the high risk 76811, that we do these planes. The fetal head, we get the BPD and the head circumference. Then we go down and get the lateral ventricle and the cavum septipellucidity, get the posterior fossa, then the upper lip and the philtrum and the fetal chest to do the 4-chamber view, the LVOT, RVOT, 3-vessel trachea. In the abdomen, the abdominal circumference, the cord insertion, the kidneys and the bladder. Go to the spine, get the axial planes and the sagittal planes. When you're looking at the extremities, get the femur length and confirm that there are 4 extremities, hands and feet. In regards to the placenta, the SMFM suggests that transvaginal ultrasound exam for suspected low-lying or placenta previa, particularly screening for those patients for accreta with risks of prior C-sections or suspected vasa previa. Amniotic fluid should be assessed with a maximum vertical pocket, and routine measurement of the transvaginal cervical length at the 2nd trimester anatomy ultrasound should be avoided in patients at low risk for preterm birth. Cervical length assessment by transabdominal ultrasound should be performed. A cervical length less than 35 millimeters may warrant a transvaginal ultrasound of the cervical length, and patients at high risk for preterm birth may be considered for routine transvaginal ultrasound. ISUOG states right up front that they have a consensus statement from international experts that these are not guidelines. They can be adapted to different countries and to individual units based on what they have available. That we should try to minimize the patient visits, minimize the duration of the close physical contact between patient and sonologist, that the sonologist can adapt and adopt any technique they wish to complete the exam, that they can save sweeps, again, of the anatomic regions instead of still images to shorten that time and do offline capturing, not only of the specific planes, but also of biometric measurements. I'd like to just go over a few practical tips that we have done at UCSD, which is the University of California, San Diego. We previously had done our anatomy scans at 18 to 20 weeks, and we have moved those to 20 weeks so that the fetuses are a little bit bigger. For the anatomy scan for patients with a high BMI, we have moved those to 22 weeks. We are discouraging transvaginal imaging due to the exposure and the time. We have found that it takes us approximately 10 minutes added on to our exam to do the transvaginal study, because not only of the cleanup, but also because we have to have a chaperone, and we no longer have the partners in the rooms to be the chaperone. We've also asked our sonographers to talk to the physician who's going to be reading their study if they have any question as to whether a transvaginal scan should be performed. And we've also told our sonographers that if the fetuses are not in a good position, then the views are limited, and the sonographers do not make multiple attempts to get that anatomy when they can't get it. So what is our protocol in the first trimester? Well, we're using the same protocol that we had initially, but we are now doing cine sweeps in the axial and the sagittal planes for the fetal anatomy, particularly including the extremities, the spine, and the bladder. We're doing a color sweep of the 4-chamber view and the 3-vessel trachea view. We have found a lot of congenital heart disease using this single sweep. Sometimes you need to have 2 sweeps, but we can often get it in 1 sweep. So we were not willing to take that out of our protocol. We get to make sure that the cine of the anatomy has the situs, or we'll take another sweep if we need to get the stomach and heart shown well in that situs, to assess situs. We're still taking 2D images of the nasal bone, the choroid, and the abdominal cord insertion, but they can be taken from the sweep and then imaged as still pictures, or the sonographer can just take them if they want. There's no longer documenting on 2D images the 4th ventricle, the spine, the retronasal triangle, the 3D multiplanar palate, or the limbs and bladder. On the 2nd trimester scan, a lot of what we did changed with the heart. We still want to take 2D and cine loops of the 4-chamber view and color across the valves. We're taking the 2D and cine of the LVOT and the RVOT, and of the 3-vessel trachea with color, and bicaval view and aortic arch that are required for the detailed exam can be done with either 2D or cine. The main thing we've done is decrease the amount of color pictures, because we were taking color pictures of all of these. And we still have told our sonographers that if they feel like they haven't been able to clear the LVOT or the RVOT with grayscale, they can certainly turn on color if they think it'll help reduce the need for follow-up. We are no longer documenting the septal views with color, the crossing of the great vessels, the pulmonary veins with color, or color images of the LVOT and RVOT. We're not documenting ankle position to prove that we have normal ankles and we don't have a club foot, but we are taking pictures in that sweep of either the feet or the ankle, whichever comes up. And we're only using 3D if an anomaly is suspected. I'll now move on and let Mishella go to do the next part.
Thank you, Dr. Pretorius, for your excellent discussion on, the current recommendations for the expedited OB ultrasound scan times. So in the next 20 minutes, I'll just be discussing more about just the expedited OB ultrasound exam time survey that we were able to, gather feedback from. Also, to focus imaging to maintain compliance with 76801, 813, 805, and 76811 billing codes. Also very helpful sweep techniques and suggestions to expedite your scan time. And 3D, how is it utilized to expedite your ultrasound scanning time and what volumes are usually taken? And also very helpful practical imaging tips. So in the past month, imaging suggestions from SMFM and ISUOG were recommended to shorten the exam time. And the reason for this was to minimize the risk exposure of the patient to sonographer or patient to physician. So here, UCSD and scripts, we followed pretty much shortly after that, and surveys were sent out, and this is what we've learned. We have learned that time is saved predominantly in the first trimester exams. Also, saving time reduces stress for sonographers. So an example, this would be physical stress. So as most sonographers know, is that with prolonged scan time and with repetitive injuries, that also causes stress, and also mental stress. So just the mental stress of the expectation of sonographers to obtain certain images. Sonographers do still take extra images for the patient, an example, the profile and even limbs, and it's because we have actually stopped using the 3D to take good face keepsake photos. Sometimes, some sonographers have mentioned that sometimes it is faster to take 2D images than to make sure the anatomy is in the cine clip. We have also gotten feedback from other institutions that consider doing a maximum vertical pocket rather than the 4 quadrants for amniotic fluid assessment. Also, we have learned that it's very important to add a disclaimer to the report that during COVID pandemic, that exam was expedited for both patient and providers. Face-to-face contact time between sonographer and perinatologist has decreased due to social distancing, and as well as face-to-face contact time between the patient and the physician has decreased due to social distancing and increased telehealth. So in the first trimester, these are just the various structures needed to maintain the billing code for 76801 and 76813. So we have to evaluate the uterus, the adnexa, and the cul-de-sac, identify the gestational sac location if present, presence or absence of a yolk sac, documentation of crown rump length. Anatomy should include cranium, abdominal cord insertion, and limbs. And of course, the first trimester nuchal translucency measurement if required. So the first trimester can be obtained using a focused sweep approach consisting of multiple sweep sets. So the set, mainly, we are going to focus first on non-fetal components, so focusing basically on maternal components. And so far, moving down, set 2 is to focus on the transverse sweep of the fetus from head to extremities. Set 3, the fetal heart sweeps from 4-chamber to 3-vessel trachea view with color only. And set 4, a sagittal sweep of the fetus, so to obtain the crown rump length for offline capture, image capture, and also focused sagittal view to take a look at nuchal translucency, nasal bone profile, and even the fetal brain. So set 1 consists of sagittal sweep of the uterus. As you could see here, this is 12 weeks gestation. It's very important that when you initially start these sweeps, you want to widen your sector width as much as possible. So here you could see the lower uterine segment. You could also see the placenta location. And by sweeping through, you could also see the placental cord insertion. And also you could get a maximum vertical pocket for offline capture image. And if you actually sweeped over more to the right or to the left, you could visualize the area of the adnexa. And as well with the transverse sweeps of the uterus, You could also see the placental location again, placental cord insertion. And just by sweeping through, you could also determine too, once you've done the sagittal sweep and you're moving on to the transverse sweep, you could actually get an idea of how the fetus is actually positioned in the uterus. And also, again, when you angle over towards the right and left maternal side, you're able to focus on the adnexa. So once we are done sweeping the maternal and non-fetal components, we can now move on to focus on the fetus. So sometimes, you know, if you have a really good angle of insonation and if baby's in a proper position, you can actually take a single clip to capture just most of the fetal structures, as you could see here in the first trimester. So in the sweep, transverse sweep, you could identify the abdominal cord insertion. You could see the choroids. If you notice, they're like butterfly shape, which are normal choroids. You could see the bladder as well. If it happens to be filled, you could also see the cranium. Also, you could identify fetal situs as well. And here you could see the stomach and the heart access. And also, as we're sweeping through, you could also see the extremities. But at times, sometimes you may need to take just a separate clip just to focus on those specific extremities if needed. And here you could see the upper extremities really well, and you could also see the lower extremities. So now when looking at first trimester fetal heart views, you know, it's very important when evaluating these structures, particularly, especially in first trimester, since they're very, very small, is you want to focus on your imaging techniques. So you pretty much want to, don't forget to optimize in grayscale imaging. You want to decrease your depth, narrow your sector width. And once you've done that, you want to turn on your color Doppler and also make sure that your color box is very small enough to, you know, increase the frame rate. And as well, you know, you want to have the right, you know, correct technique to when evaluating the fetal heart. And here you could see from this 4-chamber view sweep all the way up towards up to baby's head, you could see the 3-vessel trachea view coming into view. And these are just pretty much at the bottom, you could see the still images, or these are the offline capture images of the 3-vessel trachea view and the 4-chamber. So during the first trimester, you know, we can confirm the heart access, and at times, you know, with complex congenital heart disease with the help of color Doppler. So on a sagittal sweep set with a wider sector width, you know, depending how the fetus is actually positioned, you could actually get a nice crown rump length. But here in this clip, we're actually doing a focused view on the profile view. So here you could actually see the fetal profile. We could be able to assess the nasal bone. So it's very important to see the equal sign as well. So the equal sign, you have the top layer, which is the skin. The second echogenic line that is thicker and brighter, that represents the nasal bone. And also to take note, you want to see another little dot right above that area, which is the tip of the nose. Here we're able to see the chin of baby. Also, if you get really lucky, and usually most of the time, if you're in a true nice sagittal plane at the area of the nasal bone and nuchal translucency, you could actually capture the 4th ventricle, as we could see there. And there's the nuchal translucency. So now moving on to the 2nd and 3rd trimester exams. So, you know, there are various structures to document, to maintain the billing code of 7605 and 76811, which is the detailed anatomic scan. You know, Dr. Pretorius really showed us, you know, the SMFM imaging recommendations, which actually included this. And just for completeness, so here are just the practice parameters published by the AIUM in 2019 for the performance of detailed 2nd and 3rd trimester ultrasound. As you could see the components along with the basic 76805 and the detailed scan. And just to reiterate, you know, here we have these specific structures that I actually blown up here that are included only, which are just medically indicated. But, you know, our institutions, you know, speaking of UCSD and also with Scripps, we initially had included most of these images as part of our routine study. But of course, you know, due to COVID, we have reduced significantly specific images to minimize our scan duration times. So in the 2nd, 3rd trimester, again, you know, obtained using a focus sweep approach consisting of these multiple sweep sets. You want to start again by focusing on the maternal structures, the non-fetal components, and then sweep in for a systematic approach. By all means, you know, I have to be honest, there's really no specific order, and it's just, when you start scanning, you want to think about it, like, well, how is the fetus, positioned? If you're able to see the fetal spine, then by all means go for the fetal spine. If baby's in a good profile position, then focus on a fetal face, or even focus on a fetal heart, since we know that it is spine down. So, pretty much it just depends how the fetus is actually positioned. So again, important factors for obtaining sweeps. I felt these were important tips you have to think about, when actually obtaining these sweeps. So it's very important to maintain, proper probe manipulation and angle of insonation to focus on the specific needed structures. So an example, if you're focusing on the fetal head and you see the head, you don't want to just immediately take a sweep. You want to angle and instate and see if you're able to obtain several structures in that one specific plane. And again, as we all are imaging specialists, we pretty much know what angle of insonation to take a look at the, cisterna magna or the cerebellum, or even the lateral ventricles. Very important to optimize in grayscale imaging. And, I want to stress that because in order to get the best, image resolution, especially when sweeping, and you want to do an image capture, this is the best way to do it. You want to optimize in grayscale, and also that goes for color Doppler to maximize your image resolution. When doing the sweeps, you want to do a practice sweep in real time to see and think about what you are actually obtaining. Again, this has to be very purposeful sweep. So here, just looking, here is a transverse sweep of the fetal brain. And, as you can see here, I had the angle of insonation really on point, in which I'm able to see the choroids. You're also able to measure the lateral ventricles. If you want to do an offline image capture, you can see the cavum septi pellucidity, and as well as frontal horns. And here you can see the cerebellum, the cisterna magna, and even the nuchal fold. Now moving over to the sweep set of fetal face, this is a transverse sweep. Well, for the sweeps for the orbit and palate, we actually include that if only medically necessary. I know that some institutions have eliminated it from pretty much their protocol, but just in case that you needed it, here is actually sweep. So here you can see the orbits. It's very important, again, when looking at the orbits, you want to make sure that one orbit fits in between, no more or no less. And also when you see the fetal palate, you want to see that there's a nice intact alveolar ridge. And you could also see the toothbrush. You could appreciate that as well. And when looking at a coronal sweep of the fetal face, so here you could see a nice nose and lips, the upper lip specifically, and also you could see a philtrum, and also you can see the nose. And in profile view, here we can see a very nice nasal bone. We could also appreciate the chin, when we're assessing for any type of micrognathia. And if we're lucky at times, we are actually able to see a nice corpus callosum view if we get the right angle of insonation to look through the brain in this view. When looking at the fetal abdomen, here we have a sagittal sweep. You could clearly see the location of the stomach in relation to where the heart is. So heart is up in the chest, stomach right below the chest. And just by looking at the sagittal sweep, you could also see that you could get some arches right in the view. And going through this transverse sweep, we could see we could capture multiple views. You could also document fetal situs, as you can see the heart, the axis as well, and stomach. If you move further down towards the pelvis, you'll see fetal kidneys, also the abdominal cord insertion and the bladder. And when assessing the fetal spine, usually it's very hard to acquire or get all the spine images in one sweep. So I usually like to take it in separate sweeps, as long as I know that I'm optimizing my grayscale and I'm focused to where I need to, to see the best detail that I can. So here you can see the C spine, the T spine, and also the L spine. It's very important when assessing these sweeps, you want to make sure that there's intact skin throughout. And when I teach people, I usually tell them that the spine looks like railroad tracks or a zipper. And also a great technique when you're looking at the spine in sagittal view, you want to turn your speckle reduction imaging off. And here you're able to see all these, very fine elements of the spine. And when looking in transverse sweep, I personally like this view because you're able to just, right in the right true transverse plane of baby, you're able to obtain all the views of the spine. So here you can see the S spine down below. These are the post-image captures. You could also, looking at the L spine, you could actually see the kidneys, the T spine, and also the C spine, as you could see the clavicles as well. Again, everything's just dependent on your angle of inclination. You want to make sure that you're acquiring in which baby's in a true transverse plane, or sometimes you could make these spines look, the spine and transverse view look kind of splayed. So when looking at the heart, again, it's very important too when assessing the heart. Optimization is key. With grayscale imaging, decrease your depth, narrow your sector angle width before you turn on that color Doppler. And when you do turn on the color Doppler, just make your box small to where it's focused around the heart. When looking at the valves, also you want to make sure it's a high PRF with no evidence of, regurgitation as well. What I thought was a helpful technique is evaluating in 2D and color as a split screen. But of course, before doing this, it's very important to optimize prior to doing that. But I felt you're able to see both in grayscale and color. And here's just a grayscale clip from the 4-chamber view going all the way up to a 3-vessel trachea view. So at our institution at Scripps, we do still take a lot of the image views of the heart with color as well. We don't also look at the pulmonary veins in color Doppler. We don't necessarily take the ductal arch. We do take the aortic arch and bicaval. It just depends, if it's technically feasible too as well. And when looking at the fetal extremities, it's very helpful too with taking sweeps. As Dr. Pretorius has mentioned earlier, here you could see the ankles, just by looking at this image, we know that, there's no evidence of clubfoot. And as well as looking at the two, these are the lower extremities. You see the tibia and fibula. And as we're panning through, as a sonographer, we're pretty knowledgeable in terms of, I feel like in terms when looking at anatomy, and if there was any specific abnormality, especially suspicion for clubfoot, it will directly should just pop out. So here, obviously, these are normal lower extremities, and these are also helpful to include in your sweeps. So here, I'm sure people ask, like, well, what are the results pretty much of our expedited times? So for first trimester ultrasound for pre-COVID, used to be around 30 minutes for the ultrasound scanning time. Now for COVID, it could range anywhere between 10 to 15 minutes to do a first trimester exam. And as for the anatomy scan, usually people take around 60 minutes for pre-COVID. And now with the expedited exam, it's anywhere between 20 to 40 minutes. Now, you notice that there's a little bit of variability, and this is because, decreased exam times will vary based on, the experience and comfort of the sonographer as well. Many sonographers are still, taking the old views because they don't want to miss anything. So of course, taking the crossing of the great vessels, the septum, and, all those that are, still required for the traditional views instead of the modified protocols that we have today. With the extra time due to the expedited time, we use that time for cleaning and disinfecting rooms and also for offline capture or annotation of images if needed. So what about 3D? How is 3D, utilized during this present time, or how can it be useful? So some labs will, find it helpful to use volumes rather than cine sweeps to obtain the required planes. Although, when it comes to 3D, we all know that it is a learned skill. It's a very special skill that, that we have to practice and learn and to be able to become proficient. It's something that you just don't want to play with. It's a skill that really has to be learned. Volumes must be acquired in a very purposeful way. It's the same thing as, looking at your clips as well. Limit imaging to those images required by AIUM and ISUOG. And also we have stopped obtaining routine images that were in previous protocols that were beyond the basic guidelines. So an example, with other institutions like orbits, or taking a look at the vermis or the cavum septi pellucidity. We do document the cavum in 2D grayscale, but in cases that we were suspicious for obviously any abnormalities of the brain, we utilize 3D to look at the multiplanar views of the cavum septi pellucidity. Now there are disadvantages advantages when using 3D, and also as well disadvantages. So the advantage is rapid acquisition, which is similar to the sweeps. that we do, the cine clips, and also just potential future use of, for the volumes that have been saved, where you could actually do offline image capture or taking a look at specific structures that are pretty difficult to see sometimes in 2D imaging. Now, the disadvantages, so the lack of resolution in some planes, and all of us know that it's due to the reconstructed planes will have poor resolution. So that's one of the major disadvantages. And also, as mentioned earlier, it just takes time for training. So 3D is a specialized skill. And if it's something that you feel that you're proficient in, by all means, you could use the 3D, but of course, not during this present time. So here is just an example of a 3D, brain volume. You could see that there are multiplanar images to the left, and also these are just the views that we could obtain with the 3D brain volume. So here we could actually see the cavum septipellucidity. Also, you could see the lateral ventricles. You have a little bit of obscuring in the anterior ventricle, which is very common, but here in the posterior ventricle, you can measure the lateral ventricles. Level of the thalami, and also you can see the cerebellum with the cisterna magna. And here is another volume, which is through the face, and this is using tomographic ultrasound imaging. And here we could actually see the orbits. You could also see the palate and also the mandible in this one whole, sweep of volume. And as for the fetal heart, so a few labs have the capability to do this. This is called STIC, which is spatial temporal imaging correlation, and utilize TUI for the fetal heart. So here we could actually see the 3-vessel view. We have the RVOT view, the 4-chamber as well. You could also see the pulmonary veins, pretty much here in the area of the left atrium, and the left ventricular outflow tract view. So, this 3D is definitely, has great potential for, routine scanning, and it's definitely a skill that would have to be learned. And again, if you feel that's something that you're proficient in, then, by all means, feel free to use the 3D. So ramifications of the expedited exam. So this decreases risk exposure of medical care personnel and patients to the COVID-19 virus. Now, some subtle abnormalities may be missed. Example, such as cleft palate, BSDs, cleft foot, total anomalous pulmonary venous return, coarctation of the aorta, even a genesis of the corpus callosum can be missed since we don't utilize 3D often. Now, decreased follow-up ultrasound and transvaginal exams are being performed. So BPP usually is done in a matter of 5 to 18 minutes, but will continue to require 30 minutes if it is less than 8 out of 8. And also, it is controversial as to whether transvaginal should be performed routinely at an anatomy scan. I know certainly at both of our institutions, we don't do routine transvaginal for the anatomy scans. Ultrasound training of sonographers, students, and physicians has been eliminated during the pandemic for social distancing, and also decreased stress to sonographers. So this is ergonomic stress and also mental stress as well. So practical tips that I thought was very helpful, is you want to pay attention to the detail and angle of inclination during the sweeps. Also, when obtaining these sweeps, you want to take a slow cine sweep to get the best resolution and images for offline capture. You want to obtain sweeps in a systematic and purposeful way to improve efficiency. And time efficiency, varies pretty much across the board and is pretty much individualized based on exam indication and need. Also experience of the sonographer or the sonologist. Thank you so much.
Thank you. So we have a couple questions that have come in. And
I could ask the first one.
perfect.
Okay, so the first questions that we did get is, should sonographers be wearing the N95 mask, a surgical mask on top of that, and protective eyewear if working in the OB office, or is that an overkill? So certainly if it's an OB office, at our institutions, we wear a surgical mask. And the only time that we do wear the goggles are in cases if we do a transvaginal ultrasound or an invasive procedure. The N95 mask, we only use that if need be, in cases if we are potentially scanning a positive COVID patient that could be possibly an inpatient, or, also the N95 mask are, pretty much reserved for the front line. I have another question, and Dr. Pretorius, maybe you could answer this too. Why not FaceTime during the exam? All images and cine available to the patient on the EMR. So why avoid video conferencing during exam?
Our policy at UCSD is to never allow for videotaping the entire exam. We feel that it distracts our sonographers from taking the pictures of doing what they're supposed to be doing as a professional skill to get these views. And also it allows the patient to have video of what went on in the room, and the physician reading the images does not have access to that video. So we do not want the patients to have videos that we don't have access to look for anomalies or anything else. So that's why we don't allow it.
Okay.
Are there any other questions, Mishella?
One more question for you. Can you still bill for a 76805 if the spine and urinary bladder are not included as recommended in this expedited protocol?
I think you need to be able to say that you made an attempt and that you didn't see the bladder on the sweep. You can say that it was limited if you didn't see it. But as long as you took a video that had the area of the bladder in it, then I think you're fine in doing that billing, just like any other one that we limit certain bits of anatomy on. We do need a picture, but we don't, need to have it visible to be able to bill.
Okay. And looks like there is
A few more.
Yes, a few more.
They're still coming.
Yeah. If anatomy cannot be completed at time of the exam, when do you bring them back? For example, if exam is limited due to maternal body habitus or fetal position. What is your protocol at UCSD, Dr. Pretorius?
I think it depends on the imaging. I think each case is being individualized. I don't think that we're having one decision. I did see that they're online when I reviewed all the different protocols that the different societies have, that some are not doing the follow-up and some are continuing to do follow-up when and on another exam. So I think that has to be individualized. The goal is to decrease the number of exams and the patients coming back. So I think as a practical point of view, we're seeing less exams, patients being brought back in 2 weeks to finish the anatomy exam than we did in the past.
Thank you.
How about you? What are you doing at Scripps?
So again, like as you mentioned, it is individualized. It just depends how much we are actually able to see, because you could limit the aortic arch, but you got a good, you have decent outflows, you have a good 3-vessel view and 4-chamber. In that case, we just, they only come back if clinically needed. Now, in cases if we can't see the heart, then certainly we would probably have them come back within anywhere between, I would say anywhere between 6 to 8 weeks, depending on a need.
Okay, any other questions?
There's a few more. As an OB, I don't wear a face shield to perform a pelvic exam. Why is a transvaginal ultrasound different?
I think that we're worried about having the virus being transferred through the fluids of the vagina by putting the probe in and taking it out than if we don't do that exam. If we just do a transabdominal, then we don't have that same risk of the body fluids. So I think that is why we are now wearing goggles for all of our transvaginal. I mean, we're wearing goggles for the transvaginal exams, and we're disinfecting those goggles after the procedure.
Same here, Dr. Pretorius. Another question. we're going to skip that question here. In a state where the legal termination is 20 weeks, do you still recommend pushing anatomic and anatomy scans back to 20 and 22 weeks?
I think you're going to have to individualize that per your state. If I were in a state that had a 20-week limit, then I would probably do my anatomy scans at 19 weeks for both of those, for both BMI, elevated BMI, and regular patients. I would just feel like I need time to be able to have a second opinion study if it's needed.
And another question is, do you recommend first trimester scan to confirm your dates?
I think I read several of the societies of the guidelines that I read were suggesting that you just do your nuchal and first trimester nuchal and anatomy as one exam and not have the dating exam. But then we all know that there's going to be variations in the dating. But that was the recommendation of several of the societies.
Yeah, same here. That is correct. We pretty much for dating, we just combine it with the first trimester as well. What about GYN exams? Only if emergency?
I think we didn't talk about gen exams today, but in our department, the studies are being reviewed to determine whether they can be delayed and postponed or whether they need to be done. Certainly anything that's an ER comes to the ER and we do all of those studies like we have, continue to have our ectopic pregnancies and, our patients with significant bleeding coming in for ER or outpatient ultrasounds that are significant, but we are not doing the patients who have chronic pain or looking for uterine anomalies, things like that.
And another question is, does the physician scan after the sonographer? What about the anomaly scans?
I think that's something that you will have to decide on an individual basis for how you have done these things in the past and how your physicians are comfortable. If they feel like they have to scan a patient in order to feel comfortable that the views weren't enough, then they're going to continue to want to scan. If they're used to having sonographers that provide most of the images, they may elect not to scan. I did get different results from different sites from my survey that some places like at UCSD, they're continuing to have the physicians walk in and talk to the patients after their studies. But other institutions are not going in the room at all and just calling the patient on telephone or FaceTime to tell them what the results were.
Okay. So referring back to the question about transvaginal versus pelvic exams with OBs, not transabdominal. I believe this is referring to the goggles again.
I don't understand the question, Mishella. Can you figure it out by how it's asked?
It says why protection when transvaginal ultrasound, but why do it for transvaginal scan but not for the pelvic manual exam? That might be beyond.
Well, it may be because you're not putting your face down there. If you're looking, it just depends how you do the exam, I would say, and whether you believe that you are putting yourself at risk if you're doing a manual exam for transference of the fluids of the vagina. So that's what our team has come up with.
Okay, so for biometry, how many of each measurement should be taken? So I could answer this. So usually for biometry, as sonographers, we could pretty much assess if we're consistent, pretty much with measuring as well of the correct plane of access. And if not necessarily do you have to take 3 measurements, but if you feel like you're pretty much right on with your plane of access and it looks efficient, then then I don't think you would have to take another measurement, not unless you suspect that there's some type of growth discrepancy. How about you, Dr. Pretorius?
I don't really have anything else to add. I just think that when we have high risk patients, we have to take those measurements, multiple measurements, whether they're diabetic or whatever, that we always require 3 abdominal circumferences. If we're in the 3rd trimester and we're trying to assess for fetal weight. So I just would want to be able to get additional measurements, and not just from maybe 1 cine clip, but I might need 2.
Yes, definitely, based on the indications that are stated. And another question is, are you doing first trimester screening on everyone? If they had a dating ultrasound and negative NIPT, are they still getting a first trimester anatomy scan and a first trimester scan?
So what are you doing at Scripps, Mishella?
So we, so based on pretty much, the guideline or the recommendations is that it states that if a patient, they had cell-free DNA, they are still provided with the option to have a first trimester ultrasound. So patients pretty much, can decide whether or not they still want to have that first trimester screening.
Yes.
We still do presently do first trimesters.
Yes, we certainly do. And I would say that the state program for the state of California allows us to be able to do those first trimester ultrasounds, even if the family has decided on NIPT.
And I think that's pretty much, we don't have any more questions.
There was one question early on, they were just asking if the patient stays in the room while the physician reviews the images.
I would say at UCSD, yes, they stay in the room while we're reviewing, and so that we make sure there's not any additional images needed.
Okay.
It's rare for us to have to go back and get additional images now, but if there's some real concern about something, then we, yes, still have the patient there.
Okay, so
yeah, go ahead.
So and at Scripps, we pretty much, just depends on what type of exam. We do identify those exams that are only for ultrasound, that does not necessarily need a physician to speak to the patient. And those patients we actually do let go. So it's individualized too. It just depends on the studies.
I asked Dr. Hall whether just now via email whether they were using surgical masks or goggles for the manual exams, and he said as far as he knew they were not using them during manual exams. They were just using the gloves.
Another question is, there's more questions coming in.
Yeah, well, these will be it.
Thank you, Darcy. Are you, Dr. Pretorius, are you doing late-term ultrasounds for estimated fetal weight?
Yes.
Okay. Same here. And another question is, what is the value of waiting for fetal breathing for 30 minutes on a vented COVID patient if there is normal movement, tone, and fluid? Also, do you still include limited anatomy on your BPP exams?
I think you have to answer that, what you're doing at Scripps, Mishella, because I'm not sure.
In an example that, again, as mentioned earlier, that if you do see normal tone, normal movement and normal fluid, then, and I believe that, that'll pretty much count as your points, especially with fetal breathing. Now, the only time that you absolutely have to, I believe, wait for the 30 minutes is, is pretty much if you're seeing less than, 8 out of 8, then you would definitely wait to complete the whole exam. But if you're absolutely seeing, those components of fetal breathing, fetal movement, tone and fluid, then it shouldn't, definitely take you about 30 minutes if you're seeing it way before that. Now, another question is, do you still include limited anatomy on your BPP exams? So yeah, so limited anatomy, well, no measurements, but basically, just measuring, measurements, would that be for fluid, fluid filled structures, of course, such as the stomach, bladder, and fetal heart rate.
Okay. Well, thank you. We're at the top of the hour. So I'd like to remind everyone that a recording of this webinar will be available on the AIUM website, hopefully by this evening. Thank you for joining us. Stay well. And of course, thank you for the work that you're doing on the front lines of this pandemic. Have a good afternoon.